This is the part 2 video on gonioscopy and it is from Albert Jakobiec, volume 3, chapter number 194, page number 2484. Gonioscopy. Gonioscopy, which is the visual inspection of the anterior angle, is a valuable and in fact essential tool for the evaluation of virtually all glaucomas. The initial evaluation of any newly diagnosed case can be complete only if it includes gonioscopic examination. In addition, proper long-term management of glaucoma requires gonioscopy at appropriate intervals because the condition of the angle is not static throughout the life. It is influenced by pupil size, ciliary tone, lens size, and other changeable factors. In absolutely stable, easily controlled cases, gonioscopy should be repeated every 2 to 3 years. However, anytime a patient shows an erratic course, for example, marked fluctuation in pressure, lack of response to previously effective medications, re-examination of the chamber angle is indicated. Unfortunately, angle examination is not just a simple matter of redirecting the slit lamp by a microscope. Light leaving the chamber angle strikes the cornea-ear interface at such an oblique angle that it is reflected internally. No image can form outside the eye. To overcome this problem, various lenses have been designed that allow imaging of the angle by first neutralizing the cornea-ear interface and then providing a less oblique angle of incidence at the surface where light from the angle enters the ear. Numerous types of optical devices have been designed for gonioscopy. All of them can be categorized as either direct or indirect, and there are several useful instruments in each group. It is not advisable to select one form of gonioscopy and use it to the exclusion of all others. Each has advantages in specific circumstances. As discussed further on, Grant and Schumann advocate a careful laboratory dissection of the anterior angle of an enucleated eye as a means to enhance one's understanding of gonioscopic findings. This is an instructive exercise for the beginning gonioscopists, and repeating this exercise after gaining some clinical experience usually provides understanding not achieved at the first exposure. Direct gonioscopy with a Kippe lens provides the most natural clinical correlate to this laboratory experience and affords an excellent introduction to the technique. However, regardless of which gonioscopic technique one initially uses, this laboratory dissection is highly recommended. The image of the angle may be viewed directly or indirectly. Both types of gonioscopy have their advantages. In the direct form of gonioscopy, a contact lens with a large spherical front surface is used. This allows the image to leave the eye by eliminating the cornea-ear interface, and then to leave the lens by allowing the light to strike the lens-ear interface almost perpendicularly. A typical direct gonioscopic setup would include the contact lens designed by Kippe, used in combination with a handheld binocular microscope and a high-intensity handheld illuminating source, a Barkan light. Direct ophthalmoscopy has the distinct advantage that all features of the angle are in their normal spatial relationship to the observer. A broad panoramic view of the contours of the angle is obtained with great flexibility in viewing angle and lighting. For direct surgical intervention in the angle, the direct view is the only practical approach. Several specialized surgical lenses have been designed to allow simultaneous instrumentation and viewing of the angle. Goldman designed a lens for gonioscopy that allows the image to leave the eye by providing a cornea lens interface and then redirects the image with a small mirror to the slit lamp biomicroscope for viewing. Gonioscopy with a mirrored lens is known as indirect gonioscopy. Because of the mirror, the observer sees a reversed image of the angle. With experience, this is usually not a problem, but the initiate to gonioscopy will find this more challenging than the direct view afforded by the Kippe lens. Because the mirrored lens can be used at the slit lamp all the advantages of the slit lamp becomes advantages of the technique. That is, both the patient and the physician are already familiar with the position for examination. Therefore, no special rearrangement of the examining room is necessary. The slit lamp affords stable and well-focused illumination coupled with high magnification optics. Slit lamp-based gonioscopy also has the advantage of being directly compatible with slit lamp-based lasers. One extremely useful variation of indirect gonioscopy is a 4-mirror lens with a small central region of contact. Because the curve of the lens closely matches the anti-surface of the cornea, no special gonioscopic fluids are used, and normal tear makes the examination convenient and causes less blurring of vision than when gonioscopy is performed using viscous contact fluids. But the spatial utility of these lenses relates to their small, around 5 mm, central and relatively flat area of contact with the cornea. Because the area of contact is small and central, gentle posterior pressure on the lens will indent the central cornea, displacing aqueous fluid and deepening the periphery of the anterior chamber. This particular maneuver can be helpful in assessing the degree and synachial closure of an extremely narrow angle. Frequently, an angle will appear so narrow that usual gonioscopic techniques do not make clear whether the angle actually closed by synechy or is merely extremely narrow or even touching, but without synechy formation. By gentle indentation of the central cornea with the 4-mirror lens, the chamber can be transiently deepened in the periphery, and this differentiation can be made. If the need for iridotomy is questionable in a narrow angle situation, clear demonstration of early synechy formation by indentation gonioscopy will resolve the question in favor of iridotomy. The most widely recognized use for gonioscopy is in the differentiation between narrow angle glaucoma and open angle glaucoma. All patients with elevated pressures should have gonioscopy to make this important differentiation. Different systems for grading the narrowness of the angle have been developed in an attempt to help the clinician define the appearance of the angle in concrete terms and make some reasonable prediction of the threat of angle closure. A widely used grading system was proposed by Schaffer. In this system, a wide open angle which represents an angle of 30 to 40 degrees between iris and peripheral cornea and which allows a view of all angle structures would be graded 3 to 4. An angle that is somehow narrow, open around 20 degrees, is grade 2. The trabecular meshwork can even be seen, but views of scleral spur may be intermittent. A grade 2 angle has only a low but not zero risk of closure. However, in grade 1 angle, the angle between iris and peripheral cornea is around 10 degrees. The risk for closure is substantial. In the grade 1 angle, the scleral spur cannot be seen because of forward bowing of the peripheral iris. Only Schwalbe's line and portions of the trabecular meshwork are visible. A grade 0 angle is considered closed and allows no view of any of the angle structures. Spade suggested a somewhat more complex grading system that includes a capability for recording not only the angle between iris and cornea, but also an estimate of the height of iris insertion and of the general shape of the iris contour. Such variations serve to emphasize the difficulty of reducing the variability of angle appearances to a single numerical value. Although it may be useful to sort out gonioscopic appearances, initially on the basis of 4 or 5 angle grades, the duty of the gonioscopist does not stop there. Features such as the peripheral iris contour, the distribution of pigmentation, and consistency of appearance from one region to the next all demand careful attention. Thus, rather than rely on numerical grades, the gonioscopist should consider using descriptive language to document angle appearance. For example, open to the scleral spur for 360 degrees with mild pigment on the trabecular meshwork. It is really not possible to produce a simple and short list of gonioscopic findings that will separate normality from pathology. There are some discrete and obvious findings that will be evident if only looked for. These would include foreign bodies in the angle, large peripheral synecdoche, and proliferation of new vessels. Many of the findings are more subtle and will be evident only to observer who has an extensive grounding in the appearance and variations of the normal angle. For this reason, gonioscopy should be performed frequently, not only in patients for whom it is absolutely essential, but also in a fair number of normal individuals in order to build an intense sense of the clinical appearance of the chamber angle. For example, the chamber angle of normal infants differs from the adult angle. If the examiner has not observed a number of normal infant angles, which can be done, for example, during strabismus surgery, it will be difficult to appreciate the unique abnormality of a congenital glaucoma angle. Only by being comfortable and proficient with the technique of gonioscopy will the practitioner achieve full benefit of its ability to contribute to the care of glaucoma. Thank you so much for listening to me patiently. Tomorrow I'll be reading the Gonioscopy from Irving's, and it will be, I think, it will be covered in next 3 to 4 parts, and then last part will be on the pictures and videos related to the gonioscopic findings in different glaucoma conditions.